Good evening. This is Dr. John Bennett broadcasting from Miami. We have another in the series of Parkinson's educational hangouts with Dr. Abdul Rana, neurologist from Toronto, Canada, and a world-renowned Parkinsonism educator. Tonight, Dr. Rana is going to be speaking about multiple system atrophy in Parkinson's part 2. We talked about part 1 a couple of nights ago. Good evening, Dr. Rana.
Good evening, Dr. Bennett.
How are you doing today?
Fine, thank you. About yourself?
You're looking fit as a fiddle. Okay, Dr. Rana, let me dive into a question. What clinical features help to diagnose multiple system atrophy?
With respect to multiple system atrophy, as we discussed, it's usually divided into two main types: multiple system atrophy Parkinsonian type and the cerebellar type. The 80% of the cases are usually Parkinsonian type. When a patient shows Parkinsonism, which is poorly responsive to levodopa, this gives a clue to the physician to think on those lines. So in addition to this, there are many core features of multiple system atrophy, such as the urogenital findings or autonomic dysfunction, and cerebellar features, which may or may not be there, as well as pyramidal findings. So early in the course of the disease, the principal or the core diagnostic features may not be there. So the physician may have to look for the red flags. The red flags we discussed in the part 1. So when they look at the red flags and they find some of those, so that helps to determine or lead the physician that the diagnosis may be multiple system atrophy. The 2/3 of patients, or more than half at least, they would have a jerky postural tremor of the hands or the upper extremities on action. This jerky tremor could be due to the myoclonic contractions of the muscles, or it could be sensitive to stretch or touch. The myoclonic phenomena may also be seen in corticobasal degeneration, but it is not seen in progressive supraorbital palsy or idiopathic Parkinson disease. Also, in case of multiple system atrophy, the postural instability or falls do occur, but if the postural instability and falls occur in the first year of the course of disease, then the diagnosis is more likely towards progressive supraorbital palsy and less towards multiple system atrophy. In addition to this, patients may have peripheral edema, which is not related to medications, and about 2/3 of patients, maybe 60% of patients do have REM sleep behavioral disorder, which we have discussed in the previous hangouts. So these patients with REM behavioral disorder, they could fall out of bed, they may have a violent outburst in sleep, or they could be sleep talking, or they could be flailing their limbs, or thrashing in bed, or pinching the spouse. The REM behavioral disorder could be an early symptom of multiple system atrophy, and it could improve as the disease progresses. So about 1/3 of patients with idiopathic Parkinson disease could also be affected with REM behavioral disorder. And if the physician is suspecting multiple system atrophy and they do polysomnography and it confirms the REM behavioral disorder, so that's very supportive of the diagnosis of multiple system atrophy. Then these patients, they could have a nocturnal or diurnal stridor. So when they breathe, you can hear the stridor at that time. And if they have new onset snoring or new onset sleep apnea, that could also be supportive of the diagnosis of multiple system atrophy. And again, the confirmation of sleep apnea could also be done by the overnight polysomnography. The urinary frequency as well as urgency is commonly seen in patients with multiple system atrophy. However, it could be seen in patients with a progressive supranuclear palsy and idiopathic Parkinson disease, but the urinary urgency and frequency is more severe in patients with multiple system atrophy, and it happens much more early in the course of the disease in multiple system atrophy as compared to patients with idiopathic Parkinson disease. Another condition which is found universally in almost all patients with multiple system atrophy is erectile dysfunction. And these patients could be young males. So relatively, they are young and they have erectile dysfunction, which starts much early in the course of disease. And this could not be attributed to just age or vascular disease. In older males, it could be a bit difficult because there are many coexisting conditions which may confound this symptom, and then the physician could be in a dilemma. The unexplained autonomic failure, cardiovascular autonomic failure, is also common in multiple system atrophy and is much less frequent in idiopathic Parkinson's disease or progressive supranuclear palsy or corticobasal degeneration. Now, these patients may also have microcirculation abnormalities, which will cause the cold, dusky, and clammy extremities, and the circulatory return is compromised in these patients. In case of multiple system atrophy Parkinsonian type, they have increased pitch of the voice, though their voice is a bit thin, but they do have hypophonia and they do have monotonous speech. So it's high pitch, hypophonic, monotonous speech, or they might have unsteady, croaky element to their speech. In case of multiple system atrophy cerebellar type, these patients have slurring of speech. So they have scanning, like the words, they are scanned, they're somewhat separated, like the cerebellar speech. And another feature which can be seen in these patients is swallowing problem or dysphagia, but dysphagia is also seen in patients with progressive supranuclear palsy. Similarly, emotional incontinence with pseudobulbar crying or laughing is seen in both multiple system atrophy as well as progressive supranuclear palsy, and therefore it may not be helpful to differentiate these two conditions. Patients with multiple system atrophy, in addition, they have a sustained dystonic dyskinesias, which involve neck and face, and they could result as a consequence of use of L-DOPA. Patients with idiopathic Parkinson's disease, when they develop these dyskinesias, so their dyskinesias are a bit mobile, so they would involve different parts of the body. But patients with multiple system atrophy, their dyskinesias are usually fixed, and they are of dystonic type, and they usually involve neck and face. And sometimes in these patients, they might have their trunk, which is tilted to one side, and this has been referred as a PISA syndrome. You can see that obviously when these patients walk or even when they stand up. In addition, the patients with multiple system atrophy are usually older than 30. Not to my knowledge, the cases of multiple system atrophy has been reported in patients younger than 30 years of age. The incidence of multiple system atrophy seems to rise in fifth decade, and in these patients with multiple system atrophy, dementia is much rare as compared to progressive supranuclear palsy or Lewy body dementia or idiopathic Parkinson's disease. If these patients have significant cognitive dysfunction, which could make physicians think that these patients are demented, so that would go somewhat against the diagnosis of multiple system atrophy. Exceptions are always there. Another thing is familial cases. So not any of the familial cases have been reported in multiple system atrophy in literature, to the best of my knowledge, of course. The progressive supranuclear palsy and corticobasal degeneration, they do enter in the list of differential diagnosis of multiple system atrophy, and eye movements may help to differentiate the progressive supranuclear palsy and corticobasal degeneration from multiple system atrophy. In progressive supranuclear palsy and in some cases of corticobasal degeneration, patients do lose the vertical gaze. In progressive supranuclear palsy, the down gaze is impaired. However, it may not happen early in the course of the disease. The oculomotor abnormalities in multiple system atrophy could be hypometric scuds with a normal velocity, up gaze limitation, or square wave jerks, which are non-specific, or nystagmus. If patients have down gaze limitation, so that is very much supportive of a diagnosis of progressive supranuclear palsy.
Very good. What conditions can be considered in the differential diagnosis of multiple systemic atrophy and Parkinson's?
There could be many subtypes of atypical Parkinsonism which can be considered. However, in day-to-day practice, the idiopathic Parkinson's disease is the most common condition which could be misdiagnosed in patients who have multiple system atrophy, because patients with multiple system atrophy who are presenting with autonomic dysfunction, they could be taken as a pure autonomic failure with Lewy body pathology. And when MSA is accompanied by autonomic failure, most patients would develop other neurological features within about 5 years of the onset. The cerebrovascular disease is another consideration which can be confused in patients with multiple system atrophy. There's a condition, idiopathic late onset cerebellar ataxia. Some of the patients who have been diagnosed with this condition, they could eventually turn out to be multiple system atrophy. The late onset atypical Friedreich ataxia, spinocerebellar ataxia type 2, spinocerebellar ataxia type 3, and fragile X tremor ataxia syndrome, as well as primary progressive multiple sclerosis, could be considered in the list of differential diagnosis when assessing patients with multiple system atrophy. The hypo and hyperhidrosis, it occurs in patients with multiple system atrophy, but it does occur in patients with idiopathic Parkinson disease. I think pseudomotor testing may help further to divide these two conditions, but I don't think that is of such a significance that would guide the physician clearly in one or the other direction. The autonomic deficits in multiple system atrophy is mainly presynaptic, whereas in case of idiopathic Parkinson disease, it's postsynaptic deficit, which causes the autonomic dysfunction. In multiple system atrophy, the presynaptic element is usually normal. And ONF nucleus, which supplies the external anal sphincter and urethral sphincter, it could be involved in patients with multiple system atrophy, and a sphincter EMG may be abnormal in patients with multiple system atrophy, cerebellar type. However, it could be quite uncomfortable doing these invasive testing, and I'm not sure how many centers would consider this. The MRI may show atrophy of olivopontocerebellar areas, as well as hypointense signal in the putamen in patients with multiple system atrophy.
Oh, how can multiple system atrophy be differentiated from idiopathic Parkinson's disease?
Idiopathic Parkinson's disease is much more common in day-to-day practice and is quite asymmetrical. However, certain other characteristics may help to differentiate these two types of patients when idiopathic Parkinson's disease patients don't have a classic resting tremor. So autonomic dysfunction. The autonomic dysfunction is one of them, and it would appear early on in the course of multiple system atrophy, whereas autonomic dysfunction appears in case of idiopathic Parkinson's disease after a few years of the diagnosis. The obvious autonomic dysfunction. The subtle autonomic dysfunction could be seen, but is hard to be appreciated during a screening neurological examination. Also, both types of patients, the multiple system atrophy and idiopathic Parkinson's disease, they both could be bradykinetic, but patients with idiopathic Parkinson's disease may have asymmetry, especially early on. One side may be clearly involved as compared to other side. Response to levodopa. Patients with idiopathic Parkinson's disease respond well to levodopa to the extent that most experts take this as a spur to the diagnosis of idiopathic Parkinson's disease, whereas patients with multiple system atrophy would have a poor response to levodopa, and some patients may not show significant response at all. A resting tremor is seen in about 70% of patients with idiopathic Parkinson's disease, although it could be mild and subtle in the beginning, whereas resting tremor is typically absent in multiple system atrophy, usually, but in a very small number of cases, there could be subtle resting tremor seen in these patients, but that is also transient, usually. The appendicular rigidity is much more appreciated in idiopathic Parkinson's disease as compared to patients with multiple system atrophy, and also the axial rigidity. The axial rigidity, the midline rigidity, is also more pronounced in patients with idiopathic Parkinson's disease as compared to multiple system atrophy. And the idiopathic Parkinson's disease patients may not have any pyramidal signs, and patients with multiple system atrophy may have some pyramidal signs, although some may not have at all. The cerebellar signs are also absent in idiopathic Parkinson's disease, whereas patients with multiple system atrophy, they might have cerebellar findings as well. The cognitive dysfunction is much rare in cases of multiple system atrophy as compared to idiopathic Parkinson's disease, in which it is more common. However, in some cases, it could be late in case of idiopathic Parkinson's disease, and it may not be seen in the beginning. In the beginning, these patients may have very mild cognitive deficits, which may be assessed only by detailed neuropsychological testing.
How is the treatment of multiple systemic atrophy initiated?
Since there is no curative treatment for multiple system atrophy, so the treatment is directed at the symptoms. And when the symptoms become bothersome to the patients, they start interfering with their quality of life to the extent that they are significantly bothered by them, then the treatment is initiated. With respect to autonomic dysfunction, some of the medications such as ephedrine, these sympathomimetics may be used, but these medications at a higher dose may lead to certain side effects, such as loss of appetite, urinary retention in men, or a tremor. These patients, in addition, may have two types of hypotension. One could be the postprandial hypotension, and some patients may have orthostatic hypotension, and some may have both. In case of postprandial hypotension, so octreotide might be helpful, which can be given about half an hour before meals, about 25 to 50 milligrams. And other options could be dihydroergotamine or desmopressin, which might help these patients in case of the postprandial hypotension. In case of orthostatic hypotension, first we use these strategies like the non-pharmacological strategies, and if they don't help, then you can use medications. With respect to the orthostatic hypotension, these patients, when they're supine and they stand up, so they have a significant drop in blood pressure, and plus they become symptomatic. They feel lightheaded. And dopaminergic treatment may exacerbate their orthostatic hypotension. So in these patients, first we try salt-free diet, ample fluid intake, smaller meals, and maybe the elastic stockings, but they have to be up to thigh high. And these patients should sleep at nighttime with the head of the bed elevated as compared to their feet. And also, when they arise in the morning, just before arising, if they drink a glass of ice cold water, that would help to maintain their blood pressure. And when they go to bed at nighttime after, so at that time they could drink warm water, which would be helpful in preventing the supine hypertension. If these strategies don't help, then these patients may be tried on medications such as midodrine, which is an alpha agonist, and it does act peripherally on the arterial as well as venous system. In about 5 to 10% of patients, these could cause supine hypertension. So because it has a short half-life, so it can be used on PRN basis, only in the day or in the first part of the day, anywhere from 2.5 to 10 milligrams 3 times a day before meals. So sometimes fludrocortisone, which is a mineralocorticoid and increases the sodium reabsorption and potassium excretion, could help to increase the blood volume and cardiac output, and it could be started at a very low dose of 0.1 milligram 1 to 3 times a daily, and the dose may be increased. In some cases, it could cause supine hypertension as well as edema and hypokalemia. In patients who are on midodrine, they might have subtle side effects such as skin pruritus or urinary retention. However, these side effects are usually mild, and they might go away with the use of midodrine for a few weeks. In terms of urinary issues, so most medications may not help these patients. So they might require catheterization 3 to 4 times a day. And some of these patients may require a permanent transcutaneous catheter if the catheterization during the day may not help. Early on, when the autonomic dysfunction is mild and the urinary problems are just very mild, these patients may benefit from oxybutyrine. And with respect to constipation, so there are several strategies with respect to diet, such as adding fiber in fluid and more leafy vegetables. And sometimes these patients could use Metamucil or prune juice, and exercise is also helpful. Then other things such as lactulose or Senokot, these medications are helpful. Sometimes increasing their intraluminal volume by the microgall water may also help to relieve constipation in these patients. Erectile dysfunction is very common in men with multiple system atrophy. It is almost universal, and these patients could be quite young, and these patients may need psychosexual counseling to cope with this, because this could not only cause problems in their relationships, but it could also cause significant problems to their self-esteem. They could feel depressed, and some of them may feel a less of a man, and it could cause more anxiety. And sometimes the organic problem which they have, it could lead to even a psychological disturbances, and then it becomes a vicious cycle where they get anxious, they can't perform, which even has a more negative effect, and their erectile dysfunction does get worse. So these patients could be trained initially when it is mild. They could use the vacuum pumps or other devices which are non-pharmacological, but most patients may end up requiring sildenafil, which is usually taken before the performance, and it could help these patients. However, since it could cause cardiac side effects as well as headaches, so due to this reason, it should be supervised by the physician. And some patients who have inspiratory stridor, so they may benefit from CPAP. Some of these patients eventually may require a tracheostomy, unfortunately. Swallowing also remains a problem in these patients, and therefore early involvement of a speech and swallowing therapist could help to guide them to swallow twice, move their chin and jaw forward, and bend their neck forward, and using foods such as jello, yogurt, which are easy to swallow. And some of these patients may need endoscopic gastrostomy in the course of the disease, because even they are not able to swallow the soft diets, and they could be a risk for aspiration. With respect to mobility, physiotherapy could help to a certain extent, speech therapy as well as occupational therapy. These patients should have a home visit by an OT to have their home safe, to prevent falls. And after several years, these patients may need to be on a wheelchair because they can't keep up with their mobility anymore. Psychological support, not only for a patient, but also for their caregiver and family members, is very important. With respect to mobility, the main treatment for these patients still remains L-DOPA, and about 1/3 of patients may have a partial benefit from L-DOPA, although it's much less than in patients with idiopathic Parkinson's disease. But in the early course of the disease, it might be helpful. However, L-DOPA could make their orthostatic hypotension worse. If patients have blepharospasm, if they have focal dystonia, they may benefit from botulinum toxin injections, but the enterocolus of neck, which is seen in these patients, it usually does not respond to botulinum toxin, in most cases at least. With respect to ataxia, in the multiple system atrophy cerebellar type, not many treatments are available for this. So some reports do suggest using isoniazid, baclofen, propranolol, amantadine, or 5-hydroxytryptophan, but they all have a very limited role. So patients in the beginning, they should be advised and they should be taught the fall prevention strategies, use of walker strictly, and at nighttime when they are sleeping, they should have walker close to their bed, and they should always try to wake up their caregiver at nighttime, because that is the time which has high risk of falls for these patients.
What is the most important practical steps in the treatment of multiple system atrophy?
Multiple system atrophy is a condition which is quite challenging to manage, not only for the patients, caregivers, but also physicians. So not many treatments would be able to show any drastic results. However, we usually use L-DOPA up to maybe 1,000 milligram if patients can tolerate without becoming lightheaded. Dopamine agonists and amantadine may be tried in some cases, although the response could be very poor in these patients. With respect to bladder issues, I think the non-pharmacological strategies, if these patients can learn and they can practice, they would be very much helpful, especially in the early on the course, such as avoiding fluid at nighttime, keeping a urinal close to their bed. Before they go out, they should urinate at home, and they should plan their trip or in a certain way that when they are outside, they don't have to use the washroom. And then eventually most patients could become incontinent. So to decrease the odor of the urine, they could drink cranberry juice, which is helpful. Intermittent self-catheterization is also helpful for these patients. They should see a urologist, and they do need a urodynamic studies to look at the detrusor dyssynergia or to differentiate from the prostate problem. And anticholinergic medication with antimuscarinic activity could be helpful in certain cases, such as oxybutyrine or tolterodine. Sometimes botulinum toxin injection may be used if they have detrusor hyperreflexia. Desmopressin is also helpful in some cases, but because it could cause some electrolyte abnormalities, especially in elderly, it should be used with a caution. In terms of sexual dysfunction, I think psychosexual counseling, seeing a urologist, and ruling out other causes, such as medications, depression, and any other factors which may be causing these problems, and also a very frank discussion with your partner, being open, and would help these patients. Sometime, as I mentioned, the vacuum devices could be helpful in a small number of patients, but most patients may require sildenafil or tadalafil, yohimbine, these drugs to help them in this difficult symptom. With respect to postural hypertension, these patients become dizzy quite often, so patient education is the key to prevent any falls. Ruling out other causes such as diuretics, beta blockers, antihypertensives. Some patients, when they did not have multiple system atrophy, they are diagnosed with essential hypertension. They are treated with diuretics, and then they just stay on those diuretics or other antihypertensives. And if their blood pressure is not reassessed and the need for antihypertensives is not reassessed from time to time, so these patients may be on these medications for indefinite period of time, and it does make things worse. So their hypertension need to be assessed, and in most cases, their blood pressure medications could be reduced because these patients already have hypotension. Avoiding prolonged standing at one place, having a lot of fluid intake, salt intake, elevating head or bed, and when they sit, they should wait before they stand up, and also after standing up, they should wait so that they become steady on their feet before they start walking. Use a walker. Avoiding excessive exercise as well as alcohol is very important, and especially after heavy meals, because these patients may go out with their family members, and that ends up being a heavy lunch or a dinner. So they are out in a restaurant, and they stand up quickly and they will fall down, losing a consciousness. So if these patients can't be helped with these non-pharmacological techniques, then the medications such as Florinef or fluorocortisone or midodrine may be helpful to these patients.
Very good. That pretty well covers most everything. Not that I know about multiple system atrophy, but it seems to be a pretty comprehensive overview. Is there anything to add to this subject before we close, Dr. Rana?
I think it is a challenging diagnosis as well as a challenging management. These patients are hard to diagnose early on exactly, and then as disease progresses, their symptoms are many. They have diverse symptoms. I think having a very good line of communication between the physician, patient, and the caregiver is very important, so that every symptom patients have that could be brought in attention of the physician, and physician can attempt to address to the best possible extent.
Very good. Okay, doctor, thank you for a nice presentation of multiple system atrophy and Parkinson's part 2. And we'll see you tomorrow night. Good night.
Sure, thank you very much. Good night.
Thank you.